Hello, everyone. My name is Roxanne Chabot from RBC Consultants. Welcome to another Skin Chat webinar. Today, we're going to be sharing with you an algorithm for supporting a healthy skin barrier using skincare in newborns and atopic dermatitis prone infants. As speakers, we have Dr. Lauren Schachner. Dr. Schachner is Professor and Chair Emeritus Dermatology, Director of the Division of Pediatric Dermatology, Professor Department of Pediatrics at the Leonard M. Miller School of Medicine, University of Miami in Miami, Florida. We also have Dr. Ulrich Blume-Petavi, who is Professor and Vice Director, Department of Dermatology and Allergy, Director, Clinical Research Center for Hair and Skin Sciences, and Pediatric Dermatology Unit at Charité Universität de Medicine in Berlin, Germany.
We'd like to thank our supporters, Ceramide, for making this educational event possible.
Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will show up. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you 1 to 2 days. We greatly appreciate it if you fill in the survey and send it back to us. Finally, within 1 to 2 days of the webinar, the recording and a certificate of attendance will be emailed to you. Again, if you want to ask questions to our faculty, and we welcome questions at the end of the webinar, please use the question chat pane on the right-hand side of your screen, and I typed a little note there so you can see where you have to type in your questions. So without further ado, I'm going to pass the floor virtually to Dr. Schachner. And I've given you the mouse, Dr. Schachner.
Thank you. Well, it's a great pleasure being here with my distinguished colleague, Dr. Blume-Petavi, to talk about healthy skin barriers in the skin care of neonates and atopic-prone children, and to present you an algorithm that was put together by a European-based group of pediatric dermatology consultants to help promote this healthier skin barrier. Why is this an issue? Babies, newborns, infants have a skin barrier, stratum corneum and epidermis, that is functionally and structurally immature compared to adults. And this immaturity can be shown by measuring numerous different factors, including the thickness, because the stratum corneum and the epidermis is a third thinner, the ability to maintain the moisture, which is different and which we will talk about. And at the same time, this 1/3 thinner stratum corneum and epidermis has to protect the baby and the infant from environmental toxins, allergens, pathogens. So everything we can do to help promote a healthier barrier is going to give us a healthier newborn. I feel that ceramide-based moisturization and cleansing certainly can help that. So let's go to the polling question. Neonatal skin has higher pH, higher transepidermal water loss than adults, less defenses and cathelicidins, all of the above or none of the above. We'll allow about 30 seconds for our audience to answer. And then, well, the group did very well. The group went for all of the above, and in fact, there is a higher pH, a higher transepidermal water loss, but less defensins and cathelicidins. Let's move to the next slide. So the objectives for today, we'll look at the current algorithm, which follows a European-based PDerm expert consensus group paper on skincare approaches using gentle cleanses and moisturizers in newborns and infants prone to atopic dermatitis. That's 20% of all infants. The algorithm provides clinical information for all of our colleagues, pediatric dermatologists, and pediatric healthcare providers who treat newborn and infants. The expert consensus on ceramide-containing skin care in newborns and infants and potential mitigation of atopic dermatitis was published just 2 months ago in the February issue of the Italian Journal of Dermatology and Venereology. And we essentially had 5 consensus statements that the group could agree on. Statement 1, neonatal stratum corneum is not fully developed in function and structure. It's immature, as we discussed. The characteristic stratum corneum structure in newborns and infants may contribute to increased water permeability compared to adults and to a number of other barrier dysfunctions. 2, ceramides in the lipid bilayer of the stratum corneum play an essential role in regulating transepidermal water loss, TEWL, and maintaining skin barrier function. We see in disorders such as atopic dermatitis with skin barrier dysfunction often a ceramide decrease or depletion, and that results in reduced skin capacity to retain moisture. Serious ceramide decreases also are seen in a number of other skin disorders, not being discussed today, but including psoriasis and ichthyoses. 3, in newborns and infants with atopic dermatitis, appropriate moisturization in early infancy is important for the daily management of the condition. 4, skincare of newborns and infants should optimize stratum corneum lipid and water content and exclude agents that can negatively impact the skin barrier. Ceramide-containing skincare supports stratum corneum homeostasis. 5, parents and caregivers need to understand how to avoid irritating infant skin, whether normal or atopic, and cleanses close to physiological skin pH, which is pH 4 to 6, are preferable to water alone or to soap, which is alkaline and has a pH of 8 to 10. Now, Dr. Bloom, Tavi, and I will each discuss some of these statements. That first statement, that neonatal stratum corneum is not fully developed, is a big part of what I would like to talk about. There are abnormalities or decreases as opposed to mature skin in both function and structure. The characteristic stratum corneum structure in newborns and infants may contribute to having increased water permeability and hence less homeostasis compared to adults. This is a study out of Asia that looked at babies and adults and compared several things. And they found that transepidermal water loss rates were significantly higher in infants than adults. And that's a question you all got right on our little quiz. The stratum corneum and suprapapillary epidermis was statistically significantly thinner, 0.05 in infant skin compared to adult skin. And this was being measured by in vivo confocal laser scanning microscopy. And the skin surface enzymatic activity was different. There was more caseolytic specific activity, which led in the kids to a higher rate of desquamation, and hence one of the factors in that thinner stratum corneum and one of the challenges for barrier function. If we looked at an extensive scorecard of differences, we would then see that the infant has a thinner skin than adults, has less cell attachments, less epidermal cellularity and adherence, making it easier for everything to pass through. That the dermo-epidermal junction is flat with the lack of undulation, again, making it easier for things to permeate. There's less lipids, less melanin, less sweat, less water moisturizing content, and a higher pH. And there is a lower cis skin immune and infection protective system with less cathelicidins, less defensin, and other proteins. Now, the microbiome has similar players, but different proportions and concentrations in the commensal bacteria. So the stratum corneum in infant is not fully developed. Research out of Europe looked at the rate of development in which the pH would become more acidic, and where the skin acidification and nitration would start to get more mature. And looking at the stratum corneum, Fleur and al. In the first year and then several years of life showed that stratum corneum maturation is not taking place to a fully mature degree. It's happening, but full maturity doesn't take place for 2 to 5 years, depending on how it is studied. But that means in the first 2+ years of life, we have even more need of helping the barrier because it is immature. The pH of neonatal skin is typically more alkaline than mature skin, often ranging from 6.5 to 7.5. Lots of reasons, but a good reason is that the baby skin has been sitting in alkaline amniotic fluid during the preborn life. Yes, it has protection from the vernix caseoso, but that goes so far. We need a slightly acidic skin surface pH or acid mantle to defend our skin against infection and influence the correct composition of the commensal healthy cutaneous bacteria flora. So the process of skin acidification plays an important role in barrier maturation and the activation of enzymes involved in extracellular processing of stratum corneum lipids. So it also helps with the lipid content. So here we have newborns and infants, and we can look at pH abnormalities of elevation, decreased natural moisturizing factor, decreased lipids, including ceramides, and decreased stratum corneum thickness, all allowing for an increased transepidermal water loss and defects in appropriate hydration. Now, this maturation we've talked about starts in the first trimester in the fetus, when the basal cell begins to appear in a periderm, but no dermis is seen. A few melanocytes and Langerhans cells appear. In the second trimester in utero, we have the full spectrum of the basal layer, all the appropriate cells, and a stratum corneum appears, and a dermis appears, and the peridermis is no longer present. By the third trimester, we have the epidermis, we have dermis, and we have a more mature fetal stratum corneum, but the vernix caseosum will now appear to help protect the fetus. No noise. The vernix caseoso is a ceramide-rich fetal coating which protects the fetus during the last trimester. It consists of corneocytes and lipids, and it waterproofs the fetus while the fetus is in utero, this nice waxy substance. The vernix caseoso protects the immature barrier, both of the fetus, but also, given a chance, it will also protect the immature barrier of the neonate. Lots of places in more recent years want to hand the baby squeaky clean to the parents, nice and pink immediately. But if you leave the vernix caseoso in place, it will, over hours and several days, come off itself and leave an increased hydration, suppleness, and plasticity of the stratum corneum that helps protect the skin surface pH, making it more normal, thus inhibiting pathological bacterial growth and facilitating commensal growth. So the vernix caseoso can be a hero pre-birth and after birth as well. Statement 2, the ceramides in the lipid bilayer of the stratum corneum play an essential role in regulating transepidermal water loss and maintaining a skin barrier function. Skin barrier dysfunction, such as atopic dermatitis, which we're going to talk about shortly, Skin barrier dysfunctions and ceramide depletion result in reduced skin capacity to retain moisture. So here we have this epidermal lipid envelope made up of ceramides, free fatty acids, cholesterol, and the bi-layered lipid lamella made up also of ceramide, free fatty acids, cholesterol, as the mortar in between the bricks that are made up of stratum corneum cells. So we have corneocytes as our bricks, and this lipid mix of ceramides, fatty acids, cholesterol as our barrier, and the crucial elements of the epidermal barrier. The vernix has considerable ceramides, but as we mature, the postnatal stratum corneum may double or more the number of ceramides, and you will have some change in the cholesterol and free fatty acid content as well. But what happens if we don't have the ceramides endogenously? What do we see? Well, many skin barrier disorders in neonates and infants are characterized by ceramide content. Decreased ceramide content and an improper ratio of ceramides can make the stratum corneum incompetent. Impaired synthesis of cholesterol, ceramides, and fatty acids adversely affect lamellar layer formation, that important bilayer between the cells that make up our mortar. That will impair barrier homeostasis, leading to dryness, itchiness, irritation, erythema, the changes that we see in conditions such as atopic dermatitis, ichthyosis, cirrhosis, and even psoriasis, acne. Well, how can we explore early skin barrier dysfunction? This is wonderful work by Kelleher in Ireland. This is a study I want to really focus on with you. They measured almost 2,000 babies for transepidermal water loss at 2 days and 6 months. And then they saw the babies back and evaluated the babies using very accepted SCORAD and itchy scores and other scores. They looked at 6 and 12 months. What did they find? They found that almost 19% of the children presented with atopic dermatitis. In Western civilization and in urban countries around the world, we see at least 20% of infants and children getting atopic dermatitis in the first year of life. So that wasn't surprising. The researchers concluded that impairment of skin barrier function at birth and at 2 months was shown to precede clinical atopic dermatitis. Aha, this is the point. They could see at day 1 and 2 a decreased transepidermal water loss, and an increased transepidermal water loss. And when there was this increased transepidermal water loss, it was a statistically significant predictor of which of these 1,900 kids were going to go on and have atopic dermatitis. We could predict by day 1 and day 2, by this increased transepidermal loss, who was going to go on and be atopic. And it gives an opportunity, because early intervention with liberal use of emollients might, in some people's point of view, prevent atopic dermatitis. I would say more attenuate, decrease, delay, mitigate atopic dermatitis as opposed to total prevention. We'll talk about that a little bit more too. We can conclude that early intervention with liberal use of emollients would be good for atopic dermatitis prone kids. Interestingly, the same study suggested that transepidermal water loss might also be a predictor for future food allergies. So let's look at this nice paper 2 years ago by Alan Irving in England, looking at the atopic march. This is a complex pathophysiology of AD that translates into heterogeneous clinical presentations and trajectories. That's the big word for me. Early onset atopic dermatitis can, especially with many flares and great severity, go on to a persistent disease and lead to persistent wheezing, reactive airway disease, late onset rhinitis, sinusitis, and probably food and GI abnormalities as well. Or with good fortune, or perhaps with a good approach, including emollient-based therapies and prevention, early onset AD can result in a healthy child and a healthy adolescent, one without this airway or GI component. The atopic march is exacerbated by the younger onset of AD. If we can delay the first breakout, a family history of AD, greater severity, especially early on of AD, those are the kids who are going to go on the march. In neonates and infants with atopic dermatitis, appropriate moisturization in early infancy is important for the daily management of the atopic condition. The AD guidelines, both of the consensus-based European group and the American Academy of Dermatology, both support gentle cleansing and moisture. And in this complex slide, we're going to just pick out part of the basic therapy, and that is to have emollients and bath oils as part of your daily basic therapy. Adequate skin care and hygiene procedures, cleaning and dressing, have to be discussed as part of our role as physicians with the families. And certainly the use of moisturization and appropriate cleansing and bathing are essential. There are a lot of different reports and a lot of different points of view, including our colleagues' point of view here, but they seem to all agree that moisturizing atopic dermatitis can decrease the need for steroid use, decrease pruritus, reduce the SCORAD, EASY, and IG, the scores that the FDA and the European Union would demand to show efficacy, improve quality of life, reduce the number of flares, very important in attenuating the atopic march, increase the time to flare, perhaps very important in the atopic march, and hence play a role in either preventing or mitigating and attenuating atopic dermatitis in atopic-prone newborns. We're going to look at literature that suggests prevention, and Dr. Bloom-Patavi will look at the later Chalmers studies and other studies which don't agree about preventing, but show some different results that we can discuss. The earliest prevention for atopic dermatitis in newborns is 200,000 years old. It is the ceramide and the lipid-containing vernix caseoso, created by moms and babies with the first birth of the first human being, and remains today an essential component. After birth, we showed that the vernix could help over the initial day or so. And let's look at some studies that show how help can come afterwards. This is a study out of Scandinavia. They looked at 56 6-week-old children who already had xerosis. They gave a group oil baths and moisturizer, and they did not do that for the other group. The group that got the oil baths and moisturizer, 75% of them had normal skin at the end of 6 months, but only about a third who did not get moisturization or oils had normal skin. They concluded regular oil-based treatments in infants, including baths, would reduce cirrhosis and possibly atopic dermatitis. 2 pilot studies followed. Excellent researchers, one Simpson, one Haramaki, one a UK-based, one Japan-based. What did they do? They took high-risk kids, parents, and siblings who already had atopic dermatitis, and by 3 weeks of age started the babies on emollients. They found at the end of 6 months in the British and American group that 43% of the untreated group had atopic dermatitis, but only half as many, 22% who got the emollients, had atopic dermatitis at 6 months. So at least attenuation of the onset of atopic dermatitis up to 6 months were noted in 22% a 22% as opposed to 43%, a 50% improvement. In the Japanese group that went out 8 months, same thing. The control group had almost 50%. The emollient group, only 33%, went on to atopic dermatitis with the use of emollients. Now, several subsequent studies, as I've said, including the CHAMAs that you'll hear about in the second half of the webinar, have not concluded the same. However, the European Union are strong in the recommendation of moisturizers, forms of adequate emollients. Big amounts should be given. Moisturizing baths and soaps should be used. Moisturizers with higher lipid content are preferable, especially at dry time, like winter time, though I use them all year long in Miami. A regular use of moisturizers has a short and long-term steroid-sparing effect in mild to moderate disease, says our consensus group from Europe. After inducing with topical steroids or topical TCIs, moisturization can really help maintain the benefit. This has been looked at in a study in Canada where they used only a ceramide containing hydrating cleanser, moisturizing cream on both adults and in children in a 6-week study. And they found that at the end of 6 weeks, the children had a statistically significant improvement in AD symptoms, including itchiness. They also had less crustiness, less dryness, and a greater quality of life and good feelings about their appearance. And this is a before and after of the leg of one of the children who did receive the active ceramide treatment. So we've looked at the atopic march. We've looked at the need of moisturization and a good moisturizing program for all infants and children, and especially our atopic newborns and infants and children. We've seen that the early onset of AD, greatest severity and the great number of flares will tend children more towards the atopic march, and anything, including the use of moisturizers that might attenuate the start of the onset, the severity of onset, number of flares, certainly in the best interest of our atopic patients. At that, I will turn it over to my colleague, Dr. Bloom-Pateki, to take you through the rest of the consensus.
Yes, thank you, Larry, for handing over, and thank you for your excellent presentation and overview on our first 3 statements of our consensus. Dear colleagues, dear ladies and gentlemen, it's my pleasure now to continue with the remaining 2 statements and then demonstrate to you our algorithm we have developed as our expert groups, and to present you how to use it in daily practice and to discuss some more recommendations. So first, we would like also to start with a polling question and look for the recommendations for skincare, and you can choose in your selections between cleansers should be close to skin pH 4 to 6 and whether they are preferable to water and soap. Should moisturizers once daily be used? Can this be recommended? Is this your choice? And ceramide containing skincare supports the stratum corneum, as it has been shown by Larry. Do you agree that all these statements are correct, or do you feel that none is correct? Please vote. And we see here that in fact you have 90% have selected that all 3 statements are correct, as Larry has also demonstrated, and some think that only the first one and others that ceramides are the key. But I think all 3 together, they're important, and I would like to show you in the following now the 2 remaining statements and the algorithm. So statement 4 of our consensus paper is that skincare of newborns and young infants should optimize stratum corneum lipids and water content. And in fact, this is to enhance the skin barrier and to prevent penetration on agents that could negatively impact the skin barrier and also penetration of toxic agents. So ceramide containing skincare supports stratum corneum homeostasis, as we have agreed. And in fact, when we look it's a little delay between the slides. So in fact, why is it so important to strengthen the stratum corneum and to prevent penetration? In fact, it has clearly been shown that transcutaneous toxicity can be achieved if you use the wrong topical agent. So newborns and infants have an increased vulnerability of by transcutaneous exposures. They can even reach systemic levels. It's due to their high surface to weight ratio, the still at birth immature epidermis, which only maturates during the first year of life, and even in compromised skin barrier as it's in atopic prone skin, the fact this can even enhance transcutaneous penetration. So the use of common topical agents should be largely be considered as not using lactic or salicylic acid on a long term. Short term for few days and at low concentrations might be in some indication, but normally for enhanced application and high concentration of lactic or salicylic acid should definitely be avoided due to their systemic toxicity, which can have even toxic effects and be life-threatening. So especially in the skin diseases with impaired skin barriers. So please have a look also here on the systemic toxicity resulting from percutaneous absorption by these substances, and these should be avoided. So if you look on the care of skin, we should, that's the opinion of all the experts who have discussed this, and this can also be nicely demonstrated by the references given in the bottom of the slide. In fact, gentle cleansers and topical application of physiological lipids can improve the permeability, barrier homeostasis, and they have been shown clearly useful in maintaining skin barrier and supporting treatment of cutaneous disorders. So in fact, when we look on statement 5, we need, of course, to train our parents and caregivers in how to use skincare and how to apply it and what should be used and what should be avoided. And that's our role as pediatric dermatologists or GPs or dermatologists in general. We should train them that they should avoid in using skincare skincare with is irritating infant skin, whether it's normal or atopic skin, and therefore cleansers, when they use them, should be close to the physiological levels of 4 to 6, and they are preferable over soap and water alone. So of course we have had several studies which clearly shows that cleansers and do not harm the skin barrier when used, and they are not influencing the skin microbiome. This has recently also been shown by our group. And so if we look now, what should be the ideal moisture be characterized with? What are the ideal characteristics? It should be safe, effective, near physiological pH, and of course, additive-free, fragrance-free, and sensitizing agent-free. So it should be an ideal moisturizer which has these characteristics. And of course, parents, caregivers, and also children themselves, they like it when it's pleasant to use, when it's not stinging, when it's not, when it's really comfortable after skin application. And in fact, when it has, it's most important that it should optimize lipid and water content of the stratum corneum. And so I would like to guide you through our algorithm, which we have developed together for promoting a healthy barrier using skincare in newborns and atopic dermatitis prone infants. In fact, this is just as an overview, the poster we have presented and defended at the conference and in February this year. And in fact, the manuscript for the algorithm is submitted to the Italian Journal of Dermatology and Venereology, and I'm sure you will be able to read it soon in the literature, and we hope to have it accepted soon. But here already in advance, you will get all the details on the algorithm, how it was developed. So the scope of the algorithm was that, in fact, 8 clinicians who regularly treat neonates and infants worked together to think over and to develop an algorithm on skincare in newborns. And the idea is to mitigate atopic dermatitis in infants. In fact, the algorithm shall help pediatric dermatologists, GPs, a pediatrician and of course also healthcare providers to treat neonates and infants and to use appropriate skin care based on the clinical condition of the skin. Of course, every project has limitations, and we had to limit our algorithm that we decided that we want preventing AD is so broad that we need to discuss key studies and evidence beyond this algorithm. So prevention is not the algorithm a key topic, but key is that discussion and recommendation should look on the skin barrier in mild to moderate condition and the role of gentle cleansers and moisturizers. So, of course, also systemic medications play not a role in this algorithm, but it's a good basis for using this algorithm in daily care. How was it developed? In fact, I go briefly over this in the sake of time. In fact, it's a literature review with evidence, with selected inclusion-exclusion criteria and a review of the literature under evidence-based criteria. And in fact, as you can see here, this literature research was performed and was looked over the years of 2010 to 2021. All studies and publications found were evaluated. I show you immediately in a few seconds how it was classified, and the reviewers assigned a level of evidence for each treatment and the outcome of the studies, and then the reviewers drafted an algorithm which was discussed and evaluated by the panelists. So in fact, when you look here on our systematic literature research, you can see we found 106 publications, and they were all graded whether they were randomized double-blind clinical trials of high quality. Level B was randomized clinical trial of lesser quality, and C was comparative trial with severe methodologic limitations. And in fact, further on, a grading from 1 to 4 was added. So overall, from the 100 retrieved publication, we could include in our analysis 59. There were 23 clinical studies and 36 reviews, and even 16 clinical studies and 7 RCTs, with different levels of evidence, and also a broad spectrum of different reviews, which influence our decision in the algorithm. And so, in fact, the algorithm is mainly based first as a recommendation for general methods for skincare use for all newborns and infants, and second then on using cleansers and moisturizers, that they must be safe and appropriate for newborns and infant skin. And then is followed assessing skin problems, what we considered as a key issue that you should look on the skin, identify the skin problems, and whether it's just mild or moderate, and decide also which is the consequence, whether we can apply our skincare regimen or whether we have to do further examinations. Depending on the skin condition, we recommended in this algorithm a certain set of measures, and in fact the idea is how to improve skin barrier function. This is our key interest. So in fact, the classification system used to assess skin condition is based mainly on scaling, erythema, erosion, and oozing. Most frequent signs of a impaired barrier, and therefore we consider this is highly important when you do your selection of recommendations and which skincare should be used. So further on, here is the overview of our algorithm, which is under publication review. And in fact, the algorithm provides general skincare tips for all newborns and infants. And in fact, the basic recommendation is choose a cool environment and soft cotton clothing when you have your child to avoid further sweating or discomfort of the skin. Use lukewarm baths, not longer than 5 minutes, and 2 to 3 times per week, with consideration of gentle cleansers. When you use cleansers, please use a pH from 4 to 6. Consider always full body moisturizing after bath and even additionally in between the bath days, and avoid toxic and irritating ingredients. When you have a known or suspected AD in infants, you have no AD, you manage skin problems based on the diagnosis. Of course, you may have other conditions like psoriasis or pityriasis rubra or some of these conditions. But if you have suspect AD, then yes, you use the algorithm to look for scaling, erythema, and erosion and oozing, and decide whether it's mild or moderate or extensive, and then you do your recommendation. I will go on the following slides separately on scaling and all these classification issues. If you have mild to moderate scaling, white flaking, it's recommended to use moisturized extra dry areas more often and consider cream versus lotion depending on the climate, depending on the general situation of the skin, and this is your choice. If you have moderate to severe thickened scales, refer to further investigation or perform additional investigation. Not just use basic skincare, but perhaps another additional drug-based treatment is needed. So if you look on erythema, it's the same. Mild to moderate, less than 10% body surface, used for the symptom management. Use the moisturizers as a basic skincare to maintain the barrier function, and then this is key to have a sustained effect. If you see more than 10% body surface area involved, moderate to severe erythema, refer to further investigation and exclude other causes, or perhaps an exacerbation of atopic dermatitis, which need to be treated by more than just basic skincare. Then you go to the guideline, to the letter of the guideline recommendation, and you go first level or second, or depending on the skin condition. If we have now even erosions and oozing, if it's just small localized areas, you can perhaps still manage the symptoms with use of moisturizers or simple measures like paste for drying off, etc. But if you have extensive erosion oozing, check for super infection, check for other causes, and don't just content yourself with using basic skin care. If we go on now further, on the next slide, we can see that some recommendations here in bathing. And in summary, I would like to select several points which I think is important for recommending this to our parents and caregivers. Maintain an external environment with an ideal room temperature of 21 to 24 degrees Celsius. When you use it, a cleanser between 4 to 6, and of course, look on the frequency of bathing and time of day, depending on the family structure. Look how it suits best in the daily course, and look on also depending on countries, cultural difference should be respected. But what's always important, train them also that appropriate safety measures should be implemented, and the water should be deep enough to allow neonate shoulders to be well covered, so that it's not outside and one part inside the bath, and the mother or the caregiver is holding the baby very good to have it in an optimal position. So when after bathing you can apply a moisturizer, and therefore moisturizing should be applied from head to toe once daily for all infants. It's advantage to have an enhanced skin barrier, and it's also for babies. When you change the diaper, you don't have to do it in once the whole body, but you can do it also by diaper change. Use an emollient and you do the upper part. The next diaper change, you do the lower part. So it should not be a long procedure for the baby, but it's helping to maintain skin barrier and should be a nice and comfortable feeling for the baby and also for the caregiver, that the interaction is fine. So in fact, moisturizers containing skin lipids, it has been shown, they may offer additional benefits and should be considered while choosing moisturizer. So in summary, the skin of newborns and infants, they have anatomical and functional property that might be clinically reflected by skin, their susceptibility to skin barrier disruption. Do not forget that skin of a newborn is maturating over the first year, and that in fact it's still developing, and all these factors of skin barrier function adapt over the first year of life. Newborn and infant skin is more fragile and susceptible to infections, chemical and thermal damage. So be aware of this. And when you use skincare for neonates and infant, it should be safe, effective, and fragrance-free, as well as sensitizing agent-free. As I told you, pleasant to use, have a great galenic preparation, and choose depending on the clinical situation, on the climate, on the season of the year, choose your skincare product. So in fact, in the last few minutes of my talk, I would show you some benefits which have been demonstrated for skincare products for kids. How should they be designed, and what is important? They in fact should be lipophilic based, and in fact when you look on high-risk infants, just to finish with, this is what Dr. Schaffner already mentioned, is that in fact controlled trials examined the effect of twice daily application of ceramides containing emollient for the first 6 months of life on the incidence of AD and skin barrier function in 80 high-risk infants up to 12 months of age. And in fact, among the intervention group, children who developed food sensitivity had a later initiation of AD treatment. So in fact, twice daily prophylactic use of ceramides containing moisturizers may prevent the development of food sensitization better than daily application of emollients used in previous trials. However, today we have follow-up studies, and we have seen that this should not be confirmed. And so in a randomized controlled study looking on more than nearly 1,400 neonates with a high risk of developing AD, comparing emollient group and a control group just with mild cleansers or shampoos without moisturizers, the overall incidence was similar in both groups at 1 and 2 years of age. So the use of moisturizers did not reduce the risk of food allergy. So overall, if you see this, you can say, why should I then use cleansers and moisturizers? But to be quite clear, it is important to maintain healthy barrier to prevent and to support. Perhaps we cannot prevent with skincare atopic dermatitis occurrence or the frequency, but over long term, we prevent also penetration from toxic agents, and we provide a healthier barrier. And we are aware that even in this very nice Lancet study here published by Chalmer and co-authors, more than 2,400 newborns have been selected in this study with 4 different arms. And even at 1 year, the incidence of eczema was similar in all 4 groups. We can say that in fact, even it cannot prevent the flare-up and the occurrence of AD. We have to, or we should look in long-term studies, the benefits perhaps of a milder long-term course, or at least a better life quality, because for a more intact and strengthened skin barrier. So overall, in summary, ceramides containing moisturizers, it is clear today that we have shown in studies that lipids that help from the skin barrier, they help to retain the skin moisture and maintain hydration of the skin. It may protect, and it contributes to the protection against environmental aggressors such as irritation and pollution. And I think this is important for our children to be aware of. And therefore, formulations that contain ceramides, they mimic physiological lipids. And I think this is what is key in our management of skincare, that we support homeostasis and improve skin condition and have this as a basic management. So neonatal infant greatly benefit from frequent moisturizers use. Thank you for your attention.
Thank you so much. So again, if you would like to ask any questions to our panel, please use the question and chat pane at the right-hand side of your screen. And also, if you think of questions afterwards, you can always send them at info@rbcconsultants.com. We would once again like to thank our sponsor, Ceramide, for making this educational event possible. So we do have a couple of questions for Dr. Bloom-Patavi and Schachner. If you do not recommend soap, what do you recommend for cleansing in babies?
What we do recommend is that soap, it's not as good as cleansers. So a cleanser is a product which is liquid, which can be applied in water baths, and so it's you can say it's a liquid soap, but it has different characteristics as a soap which has a pH from 8 to 10, and so you keep in the physiological level. I think this is the key. You should always use around this physiological pH from 4 to 6.
At what age would you start bathing a newborn?
Oh, this is a very good question, because we have looked in studies, and we, depending on the habits of each birth clinic, you must say that some birth clinics or midwives only bath the baby when the umbilical cord has fallen. Others bath directly after delivery. So in fact, what we are aware today is, as Dr. Schachli nicely showed, the vernix caseosa on the surface, when it's there, you just wipe it swiftly off. But if these lipids can maintain 1 or 2 days on the skin barrier, it's on the skin, it's great. It's a great support and natural skin care. and you just take off the meconium, you just take off a really blood crust or something. This you slide. But bathing, it depends really on cultural habits. But we have done in certain clinical studies, we have looked after 5 to 7 days. But you can bath also the first day depending on your habits and experience. I don't know what Dr. Schachler thinks, but this is my opinion.
I agree entirely, and I think it was very important to reiterate allowing the vernix caseoso to do further work. It's a great friend helping the neonate adapt to an external environment that is drier and much different and has pathogens in it as compared to an alkaline amniotic fluid environment where the baby has been for the prior 9 months. So I think your statement is right on target. And I also entirely agree with the concept of not using soap, but using moisturizing cleansers that have a pH in the at least over 4.5 and up. Sometimes there are some that have a pH even below 4.5, and that is a little irritating to babies. But 4.5 and up, especially to 6, seem to be a favorable range.
Do you see differences in frequency of bathing and use of moisturizer, whether it is maintaining a healthy skin barrier in healthy infants and infants with atopic-prone skin?
If I may start, perhaps, the frequency of bathing, I think in atopic-prone skin, as we have written in our paper, 2 to 3 times a week. But once again, we have had over the past 10 to 15 years several discussions, and it depends on the cultural habits in each country. If you are in Africa, if you are in Europe, all over the globe, it's done depending on the conditions. But we must be aware, if you bath your baby, you can use a moisturizing cleanser in the bath also. But what is the most important is using even a moisturizer after bathing or in the between bathing days.
So I agree again with my distinguished colleague, Ulrich. In Miami, where I'm located, is exceedingly multicultural. So you have to be sensitive, and skin of color populations have different types of approaches, and we go with it. I think more important than the frequency of bathing is talking to the family about not doing exceedingly prolonged bathing. A lot of families feel that, well, if 5 minutes is good, then 20 minutes is 4 times as good, but it's not, especially in atopic children. It changes several important barrier properties. 5 minutes or so really is kind of the maximum that a baby needs to maximize the potential benefits of a bath. 10 minutes and up start having a decreased benefit and cause some problems.
It appears that earlier studies looking at the effects of early moisturizing to mitigate AD were done with a variety of moisturizers rather ceramide containing moisturizers. Could this affect the results of those studies?
Well, yes, it's a hypothetical question, and the answer is a hypothetical yes. I really think there's a fascinating need to do a deep dive in all of those studies, because some of the studies stopped at 6 months, some stopped at 8 months, others are looking at 1 to 2 years. If we do a deep dive and we find that, in fact, while we're not going to prevent eventual atopic dermatitis, we might decrease the onset, we might stretch the onset date of the first flare, that would be a good thing based on work on the atopic march. If we find that during those first 6 or 8 months looked at by Simpson and colleagues, that there are fewer flares, that would be a good thing. So I think there's a lot of data that we have to look at to make good decisions. But certainly the choice of emollients, all of the moisturizers are not created equally. And so the possibility exists, yes, based on Lynn and others' work, that perhaps there may be an increased benefit had ceramide-based moisturizer has been used in these studies.
In what disorders do you see decreased ceramides?
Well, Enrique, if you look at the literature, two of the most frequent would be atopic dermatitis, but also psoriasis, and also, maybe surprising to some, even acne. Among babies, we of course think about babies with ichthyoses having decreased ceramides and other xerosis type conditions.
Any complications of unresponsive use of emollients like skin infections?
What is the question?
Any complications of unresponsive use of emollients like skin infections?
Okay, just two ideas. I don't know whether I get the question correctly, but the point is skin infection that's why we have done it very clearly that if you have erythema, scaling, mild to moderate, you can try it for a given time with some moisturizers. But if you see that after 1 week you have no improvement, or even after several days you have worsening of the skin, you should reconsider your moisturizing treatment as a standalone. But complications of moisturizing, I do not see, if I understand it correctly, but perhaps what I did not explicitly hinted in my talk is that when you use your moisturizer, don't get with your fingers in the recipient, use a stick or something to get the cream out. What we have seen in the past is that if a cream or an ointment is open too long and gets super colonization with bacteria, and you have not sufficient preservative in the cream, then you can distribute topically the ingredient of the cream. But this is more a complication of a wrong use and contamination of your product, what you as a user, as a parent, caregiver have contaminated, but not really a complication. If the question goes to the question of contact dermatitis, in fact, in newborns and infants, this is rarely seen. If you look on all the baby skin care products, they have really been developed with ingredients which are highly selective for pediatric skincare preparations, and what is used in adult products and for other cosmetics in normal healthy users is not in a baby skincare product. So I think this is, from production status and conceiving a skincare product, already not in the product itself. So I don't have seen any complications. Sometimes they don't like, if it's urea in it, they don't like because it's itching, it's stinging, burning, but urea you do not use below 2 years of age. So it's more the wrong choice of the product you have done, and it's not for newborns or young infants suited. I don't know, Larry, what you think?
Oh, I think it's a terrific question, and I think you gave great information in the answer. I'm going to add a little bit my thoughts, agreeing with Ulrike in so much of what she said. There are some very popular emollients that contain lanolin, for example, and over the course of time, they may be sensitizing to some of the population. So I would keep that in mind if I have an atopic. And they say, wow, the moisturizer seems to be causing a little bit of a problem. But most of the time, I entirely agree with what Ricky said. And the thing I often tell parents, they often say to me, they ask the question, is there, a problem, or is there a point when I should know that I'm applying too much emollient? And I tell them, if they go to hug their child and the child flies up to the ceiling, they've overdone it a little bit. But short of that, the use of emollient is fine, and as Ulrike said, a very benign and important part of the skincare of the well baby and the AD-prone baby.
Larry, this is exactly the point. Perhaps I forgot to mention additionally which emollient you use, whether you use a lotion or cream, depending when it's very hot outside. You should not use a Vaseline, which makes a whole body occlusive effect. Then you can have a complication. Of course, you prevent the skin from perspiration, and then it's a complication of you. But therefore, I said the galenic preparation must be adapted to skin condition and also climate and season. So you have to adapt, and that, I think, this is the art of a dermatologist to decide what is to be used.
And of course, being in Miami, we have to be very sensitive to that, Ulrike, because it's generally hot and humid year round. So if you're putting a very viscous type emollient on, you're going to induce miliaria, which is the effect of not allowing the eccrine glands to function correctly. So we're total agreement and an important point indeed.
Maybe one last question. Actually, there's a couple of great questions, but
Are there any factors influencing choice and frequency of using moisturizers?
I wasn't able to hear the question.
Nor do
Are
I.
there any factors
influence.
You are very.
Am I low?
Yes,
Now you're
you're
better.
better.
Okay, sorry. Are there any factors influencing choice and frequency of using moisturizers?
I think we just answered it. It's climate, it's situation, season, it's of course habits. In Africa, most of them use other products, what is locally available. I think these are key factors. But when it's and the skin condition, the oozing skin would not ask for Vaselinum. They would ask for a lotion or a cream.
That is a subtly fascinating question, I find. I'm glad it was asked. If you go to a pharmacy in the United States and you go to the area where they have moisturizers, there are 100 different moisturizers. It could be bewildering to your families. So there's a number of considerations, and one of them is cost. And in the United States, there are wonderful emollients that you can get 100 grams for well under $10, and they're perfectly fine. You can also spend $250 on a prescription emollient, which won't give you much more benefit, if at all, than the $8 or $9 emollient. So cost is one thing to consider. Climate is one thing to consider, and always listen to your families. If they give you feedback that emollient moisturizer #1 seems to be of some issue, some of the issues that Ulrike raised, like the miliaria, you have to hear it and you have to modify. But I think one of the things that Ulrike had in her bullets on what makes a good moisturizer is patient satisfaction, and I would say cost should be considered as well.
Well, that's all the time we have today. We would like to thank Dr. Bloom-Batavi as well as Dr. Schachner for a very thorough and clinically practical presentation for pediatric patients. And we'd like to thank you all for joining us. Goodbye, everybody.
Bye.
Bye now, been a pleasure.
Thank you.